Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Peace, YouTube. I'm your moderator and narrator, Uriel Neveu Riley. So, we pick up in chapter 16. Peace. Welcome. In the middle of page 264. Welcome, YouTube. All right. Your peaceful reading for the evening and day. Love to all my friends and family, all my mods. I love you so much. I'm here. Incidents of airway contamination. Any interruption of the normal defense mechanism of the lower airway for even a very short period of time will result in contamination of the lower airway. In spite of rigorous sterile techniques, endotracheal tubes inserted for periods as short as 30 minutes will result in a high incidence of contamination of the airway. The placement of an artificial airway for more than 24 hours will result in contamination of the lower airway. The respiratory care practitioner must understand that airway contamination is an inevitable result of artificial airway placement. This occurs regardless of how well the airway is maintained. Common airway contaminants. The most common contaminants are gram-positive organisms, usually Staphylococcus or Streptococcus. These gram-positive bacteria are normal inhabitants of the upper airway. It is not surprising that they would contaminate the lower airway following the establishment of an artificial airway. In debilitated patients, especially in intensive care areas, it is common to have gram-negative organisms contaminating the airway. In order of commonality, they are Klebsiella, 2, Pseudomonas, 3, Escherichia coli, 4, Enterobacter, and 5, Proteus. Gram-negative organisms are dangerous when they cause pulmonary infection because 1, they destroy lung tissue, necrotizing pneumonia. 2, they cause generalized sepsis, gram-negative shock. And 3, they require highly toxic antibiotics for eradication. Top of page 265. Prophylactic antibiotics in respiratory care. Antibiotics have proved to be successful in treating pulmonary infection. However, their misuse can be as dangerous as the appropriate use is advantageous. There are numerous clinical circumstances in which the preventative or prophylactic use of antibiotics has proved to be a great benefit. In patients who have contaminated surgical wounds, the starting of antibiotic therapy prior to clinical infection plays a great role in decreasing morbidity and mortality. Although this principle has proved valid in many clinical circumstances, there is little evidence that prophylactic antibiotics are indicated in acute pulmonary disease. The treatment of airway contamination with antibiotics results primarily in the suppression of the more common contaminating organisms, guaranteeing that if infection occurs, it will be due to a potentially more dangerous gram negative organism. The use of prophylactic antibiotics must always be a medical judgment based on each particular circumstance. We make the general statement that routine prophylactic antibiotic therapy for airway contamination is contradicted because it may lead to dangerous and difficult to treat pulmonary infections. A clinical generality may be stated as follows. Pulmonary infection must be treated by appropriate antibiotic therapy, whereas airway contamination must be repeatedly evaluated but not treated. Nosocomial infection in respiratory care. Down at the bottom, peace, highest heart love. Welcome to the YouTube live book reading of clinical application of respiratory care. We're in the 16th chapter, page 265 for those reading along and in the playlist. Nosocomial infection in respiratory care. Nosocomial infection means infection that is transmitted to the patient by hospital equipment or personnel. This is a great danger in respiratory care since we deal with equipment that is in direct communication with the airway. Aerosol therapy is a great source of nosocomial infection because bacteria are transported on water droplets. It is incumbent upon those in respiratory therapy to be sure that a patient's airway is not cross contaminated by the respiratory therapy equipment. We cannot prevent the patient with an artificial airway from becoming contaminated, but we can protect him or she from becoming contaminated with other patients' bacteria via the respiratory therapy equipment. General equipment precautions must be followed, such as providing single patient units or circuits in aerosol and IPPB therapy, providing the appropriate filters on equipment, changing the parts of the equipment that come in contact with the patient at least every 24 hours, carefully draining condensate out of tubing so that the moisture is not stagnant, and carefully culturing the respiratory therapy equipment periodically to make sure that proper sterilization techniques are being carried out. Ding! The cleaning, very important, right? That's why man, sterilization of the equipment so there's no cross contamination. We have to log that. All those taking notes and respiratory practitioners and aspiring respiratory techs and doctors, MCAT takers, we're here for you. Reading this to you for free. Highest heart love. This is thousands of dollars of information, you know. We're on this peaceful part of YouTube. We read books and learn from masters. So thank you so much for being here, Skinny Legend. Highest heart. Anyone caring for a patient with an artificial airway must maintain meticulous personal hygiene between patients. The simple technique of hand washing by those coming in contact with the airway will significantly reduce the possibility of cross contaminants. All right, in the middle of page 266, in the 16th chapter. Hi, it's Heart Love. Thank you for being here and reading with us. Intensive care and airway contamination. Positive sputum cultures may be due to one of three possibilities. One, contamination of the specimen. Two, contaminating colonization of the tracheobronchial tree. Or three, clinical infection. In addition to the factor that an artificial airway practically guarantees contamination of the airway, there are numerous factors responsible for the high incidence of pulmonary infections in intensive care units. One, extremely high patient density. Two, critically ill patients who have poor defense mechanisms to ward off infection. Three, contaminated respiratory therapy equipment. Four, injudicious use of antibiotics. And five, improper technique by ICU personnel. Summary. One must consider the insults to normal defense mechanisms produced by the placement of an artificial airway. One, the inevitable contamination by bacteria of the lower airway. Two, the disruption of ciliary motion that occurs when a foreign body is placed within the trachea. This loss of normal ciliary motion greatly inhibits the functioning of the mucociliary escalator, which we know is about moving the fluids, right? The ciliary. Excuse me. Oh, you see that? Wow. Excuse me. Thank you. Moving the secretions. It's most important, right? We gotta let it go. All right. That's a you see that? That's how it goes. Complete alignment. Three, placement of an artificial airway interferes with the most important productive or protective mechanism in mobilizing retained secretions, the cough mechanism. Any patient with an artificial airway is greatly impeded in his or her ability to cough, and the chances of retaining secretions in the pulmonary tree are greatly increased. Yeah. Excuse me. Wow. Should have turned my mic off. These overwhelming factors make the critically ill patient with an artificial airway vulnerable to pulmonary infection. Colonization with pathogenic bacteria is universal in patients in whom endotracheal or tracheostomy tubes have been placed for longer than 24 to 48 hours. Bacterial cultures are difficult to interpret and must be considered intelligently. Inappropriate use of antibiotics can lead to more serious clinical infection, although the prevention of bacterial colonization is a worthwhile area of investigation. It appears impossible to prevent. Here comes another one. Excuse me. Wow. Three. That was a magic number, I guess. The inevitability of contamination of the airway must not be interpreted as an excuse for poor technique in airway care. It is well known that poor technique leads to a much greater incidence of serious pulmonary infection. We must always strive for the best of sterile technique in both our equipment and airway care. All right. So, top of page 267. We're in maintenance and extubation, chapter 16, suctioning the airway. Since the patient with an artificial airway is not capable of effectively coughing, the mobilization of secretions from the trachea must be facilitated by aspiration, suctioning. Patients with copious secretions will require frequent suctioning. Serious complications, including cardiac arrest, may result from improper techniques of aspirating secretions from the trachea of critically ill patients. Thus, it is essential for us to review the complications of suctioning and the state principles upon which proper techniques are based. Complications of airway suctioning. Middle of page 267. The major complications of airway suctioning are 1. Hypoxemia, 2. Arrhythmia, 3. Hypotension, and 4. Lung collapse. Hypoxemia. Most patients with artificial airways are receiving some form of oxygen therapy, i.e., they are breathing enriched oxygen atmospheres that are essential for the maintenance of adequate oxygenation, arterial oxygenation. When a catheter is placed in the airway and a vacuum applied, oxygen enriched gas is sucked out of the lungs and replaced by room air that enters around the catheter. Thus, we are we wow. We are replacing oxygen enriched air with ambient air, 21% oxygen, a circumstance that would result in severe hypoxemia. 1 of the earliest discoveries in respiratory care units was that most of the cardiac arrests occurred either during or shortly following the suctioning process. Just had to let that sit for a sec, right? Hi, it's Heart Love. Thank you for reading with us. Man, we're pushing towards 600 new subs. Man, it's been an amazing ride. Just reading books, not just, but amazingly, reading books. All books on this channel. And I honor you. Thank you all to the book lovers community, all of our friends and family. Man, highest heart love. This is beautiful. It really is. Hmm. All right. Acute hypoxemia during the suctioning process will manifest heart rate abnormalities in the critically ill patient. Most often, there is an initial tachycardia without arrhythmia that reverts as soon as oxygenation is reestablished. Occasionally, the adult will manifest a bradycardia. Any significant change in heart rate or rhythm during suctioning must be presumed to be due to hypoxemia. Ventilation and oxygenation must be immediately reestablished. Pre-oxygenation is useful in avoiding hypoxemia during suctioning. Of greater importance is the technique of providing an oxygen enriched atmosphere around the catheter so that room air does not enter the lung. Arrhythmia. Significant cardiac arrhythmias may occur during the suctioning process from two sources. One, arterial hypoxemia leading to myocardial hypoxia, or two, vagal stimulation secondary to tracheal irritation. There still exists great debate about which of these two factors is most significant. They both play a potential role in the initiation of severe arrhythmia, such as premature ventricular contractions during the suctioning process. True vagal stimulation may lead to profound bradycardias. These complications can be best be avoided by appropriate technique. Yeah. Hypotension. Hypotension may occur from either of two circumstances. One, profound bradycardia resulting from vagal stimulation, or two, prolonged coughing maneuvers during the suctioning process. Tracheal irritation from the suction catheter may stimulate tracheal and carinal reflexes, resulting in paroxysmal cough like maneuvers, which interrupt the ventilation. These coughing maneuvers, along with bradycardia, can have a severe effect on both venous return and cardiac output. Hypoxemia, exemia, arrhythmia, and hypotension are best avoided by suctioning techniques that 1. Include pre and intermittent oxygenation with high inspired oxygen concentrations. 2. Limit the suctioning process to 10 seconds or less. That's very key. And 3, including closed cardiac monitoring. We'll pause right here. Thank you so much for reading books. Hi, it's Heart Love to all the brilliant lights and light workers out there. We're in the 16th chapter of clinical application of respiratory care. Hi, it's Heart Love by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. So when we reconvene, page 268 and the bottom. Thank you so much for reading with us on this, wow, 45. So now this next one will be 46. All right. I wish you have a wonderful evening and rest. All my loves, all my family and friends, you know I'm praying for us, wishing the best for all of us. And thank you. Thank you. All that I have now and all that is coming to me. I'm so grateful and thankful. I'm so grateful and thankful. This is my dream come true. I'm reading books to the people live, so there's no commercials, right? I love you so much. All right. Thank you for all my friends and family, all the mods in the building. Hi, it's Heart Love. Let's have a glass of love water. To all the righteous, to all the light workers, all the healers. Where? Archangel energy. Love. Shaking it up on YouTube, right? Love. Mm. Oh, love you. I love you. I love you. I love you. Oh, we really do shake it up. This is what we do, right? Oh, thank you so much. All right. Hi, it's Heart Love. I'm Master Uriel, Neveu Riley, Master Fitness Trainer. And so, I know the vocabulary is really up there, but it's in my line of work. And that's what us light workers are do. Bring it to you for free. We want the best for all of our friends and family, you know. And that means speaking life into one another. So this is the peaceful part of YouTube where we read books and learn from masters. So, yeah, I see you. Peace, CW10. Hi, it's Heart Love. Yep, we're shaking it up. Reading books, medical books, $1,000 worth, you know, to the people for free. That's what we're supposed to do. So peace to all the light workers. I love you so much. Hi, it's Heart Love. That's right, Nancy. Protect our peace. We have to know how to protect our peace. And so when we cultivate the world around us, we start to resonate on certain frequencies. We know when it's disruptive or not, right? And then we start to realize when there's forced resonance, when it's someone trying to put their will into over you to make you do something or control you. That's forced resonance, right? So we stay in the harmonic, sympathetic resonance. I love you. Thank you so much for being here. It's heart, love, and honor. I love you. I love you. You know, peace, peace. I'll see you soon when we reconvene. Peace. Thank you so much. Yeah. Awesome. They look like this. Oh, that's love. Yeah. That's the peaceful part of you too. Yeah. Angel energy. So I love you too. Seni se yore. Peace, peace.